who doesn't know you. Other people all know you very well, I think.
Okay.
So I thought that Dr. Balan doesn't need any introduction. That's why I allowed. But Dr. Balan uh, is an associate professor of um, PGI Chandigarh, and now he's in next gen path. He's reporting all our pathologies and histopathologies, and because of him, a lot of patients' diagnosis were pinpointed, and very rare diagnosis and all we have done, and a lot of patients have really benefited by this. So, just a brief thing about sir, but sir, I'm sure sir will be able to give a better. My father would have given a better introduction, but really, hats off to you, sir, for all the marvelous work for over the many years.
Thank you for the kind introduction. So we'll move on, and as I said, liver has various functions, and one of the key functions is metabolism. So whenever we have any problem with liver, the liver function tests are the first set of tests which will be done, which will be done. That will indicate the type of liver disease. And more importantly, with respect to liver, as compared to the other organs, it has an extensive method for regeneration. So coming to the liver disease, most of the indications for medical liver disease, that is diffuse parenchymal liver disease, is abnormal liver function test. And once the diagnosis is made out in the liver biopsy, the next part for a pathologist is to assess the severity, that is activity, and whether there is any chronicity in the form of fibrosis or not, and to grade or stage the fibrosis. So these days there is a concept of regression of cirrhosis. So initially it was thought that cirrhosis doesn't regress, but in some conditions, especially when the septae are thin, there is a propensity for the cirrhosis to revert back to some extent. So after treatment, that there may be a serial biopsies which may be done to assess the fibrosis, whether the fibrosis is regressed or not. And also non-invasive methods like your fibroscan are helpful in these cases. There are certain emergency indications for liver biopsy, especially acute liver failure and transplant liver biopsies. So the commonly received liver biopsy is the percutaneous ultrasonographic liver biopsy. In certain cases where there is a high chance of bleeding, especially in cases of coagulopathies, we go for a transjugular liver biopsy. And there is wedge liver biopsy, which usually is done by the surgeon. Most of the time, it will be a part of a major surgery. For example, a cholecystectomy or an appendectomy or something like that. The surgeon will usually find something grossly visible, especially a tiny nodule in the liver, which may be protruding from the surface. So they will take a wedge biopsy of it. Or sometimes, if the surgeon thinks that grossly the liver is shrunken or something, and he suspects.
Can I, sorry, just interrupt? The slides are not changing for me. Is it changing for everyone? Everyone is it
For me,
changing?
it's changed. Yeah, for me, it changed.
Okay. Ebenezer, sir, Mr. Ebenezer, is the slides changing for everyone? Or Karthik or Surya, can you see a different slide or only the first slide?
First slide only, man.
Actually, sir, the slides are not changing. Can you maybe stop presenting and again start presenting? Now it changed. Now it changed. Yes.
Okay.
Now you can see. Yes.
Okay. Now that slide has changed.
Yes, sir. Now only it has changed. Yes.
Okay, fine. So that's what I was saying. This is a percutaneous liver biopsy. As you can see that the liver core is much thicker and much longer as compared to the transjugular liver biopsy. Percutaneous liver biopsy is the routinely performed liver biopsy, and transjugular liver biopsies are performed especially when there is a risk of bleeding. And the idea of doing a transjugular liver biopsy is the bleeding will occur within the blood vessels. So basically, blood doesn't come out. So that is how it helps prevent bleeding. But the only problem is this is very technically difficult. And as compared to the percutaneous liver biopsy, interpretation of transjugular liver biopsy is also very difficult. And coming to the wedge biopsy, as I told, usually it is done by a surgeon, not necessarily an indication, but during an intraoperative finding, there may be a nodule in the liver, or the liver may appear firm or something, where the surgeon has a suspicion and he may take a wedge of liver. So the percutaneous and transjugular liver biopsies are medical biopsies, and wedge biopsy is a surgical liver biopsy. So there is now that the slide is changing, right? I've changed it. Can just someone
Now it's
confirm?
changed to the next slide. It's the same.
Okay.
Now it's changed. Yes, sir.
Okay, what I will do, I'll go back and I'll again present. That will be easier. Okay. So there is a caution with respect to wedge biopsy, because normally there will be fibrous bands which will be coming from the capsule into the liver parenchyma. However, these fibrous bands, they do not extend more than 2 mm into the liver. So up to 2 mm in wedge biopsy, fibrous bands are normal. So that should not be interpreted as fibrosis. So this is for the pathologist who is practicing. Whenever they get a wedge biopsy, the fibrous septate of not more than 2 mm in a liver parenchyma is supposed to be normal. So coming to the adequacy criteria, so there are various studies and various publications with respect to the adequacy and indication of liver biopsy. So ideally, the studies say that the liver core should be at least 3 cm long after formalin fixation. So not the biopsy which we take after before fixation is not taken into consideration. So once we receive a sample, after formalin fixation, we need to estimate the length of the biopsy. It should be 3 cm. And usually preferred is 16G needle by ultrasound. And for transjugular liver biopsy, since the bore size is very low, that is 19G, at least they recommend 4 passes so that we get an adequate number of portal tracts and adequate parenchyma for interpretation. So that is why in a liver biopsy we need to look at least 6 portal tracts to be sure that we are dealing with a sufficient liver biopsy. However, the level of evidence is deep. So there are liver biopsies under special circumstances where unfixed tissue or dry tissue is used for measurement of iron or copper, especially in cases of hemochromatosis and Wilson's disease. Fresh tissue for frozen section in special considerations like mitochondrial diseases, acute fatty liver of pregnancy, certain metabolic diseases, and selection of donor liver. So as you know that for donor liver, cadaveric donor liver, we will usually assess for the fatty change and other parameters. But the most important parameter is fatty change, for which always fresh tissue is sent. And most common practice is to send 1 cord from the left lobe, 1 cord from the right lobe, and a wedge. So all the 3 should be assessed for the fatty change and the percentage of fatty change. So when I mean fatty change, it is macrovesicular steatosis, and microvesicular steatosis is not considered as an important parameter. So once the cutoff exceeds the recommended cutoff, for example, if it is more than 30%, then usually the liver will not be taken for transplantation. And then again, rare circumstances, especially when there is electron microscopy, which we need to look into certain liver diseases. Neural decade is a fixator, where one particular portion of the core is put in neural decade for electron microscopic examination. So coming to the functional anatomy, As you know that the oxygen gradient, and metabolic heterogeneity of the various metabolites, there is a differential distribution of enzymes across the three zones of the SNI, and that explains the zonal distribution of liver cell damage due to ischemia and toxic substances. So I'll be discussing in further and with the images how the gradient is utilized by pathologists to know the what disease we are dealing with. So this is the classical lobule concept described by Kiernan in 1833. Here they had the central vein as the center part of the SNA and the portal tract as the peripheral region of the SNA. But the current concept is the acinar structure proposed by Rappaport in 1954, where the portal tract is considered as the center part of the liver, and central vein is considered as the tertiary part. So the zone 1 will be the periportal, zone 2 will be the centrizonal, zone 3 will be the centrizonal, and the zone in between the zone 1, that is periportal, and zone 3, that is centrizonal, will be zone 2. So whenever we look at a liver biopsy, we look and describe in terms of the zonal pathology. So once we describe the pathology in terms of the zonal distribution, we will have a particular idea of what type of disease are we dealing with, and hence we will be able to arrive at a differential diagnosis. And by using ancillary studies like the special state immunohistochemistry, we'll be able to come to a relatively one or two. So this is how the liver appears by ultrastructure. As you see that this is the portal tract and this is the portal vein, hepatic artery, and these are the lymph vessels and the bile ducts will be there. So this will be the portal tract, and the three structures which I said, the hepatic artery, portal vein, and bile duct, will form the portal triad, and there will be connective tissue which are surrounding the three structures. Usually, in microscopy we will not be able to appreciate the lymph vessel, so I will be discussing it later. And here, this is the limiting plate. The limiting plate is nothing but the first row of hepatocytes which are surrounding the portal tract. So there are very strict definitions for certain terminologies in liver. For example, interface hepatitis is whenever the inflammation crosses this limiting plate, we call it interface hepatitis. Otherwise, it will be just a portal inflammation. So coming to the normal histology, whenever someone is given the slide in their exam, the first question will be asked, how do you say it is liver? So it is very simple. The liver is the only structure which will contain portal tract. So no other structure in the human body which is going to have the portal tract. So the portal tract will have the common triad, that is hepatic artery. This is the bile duct, and these are the portal veins. So whenever we find these three structures, it is called as a portal triad. And this acellular material which is surrounding these structures is the portal connective tissue. There can
Sir,
be.
can you please show it once more, sir? Your
Okay.
mouse is very small, so on the mobile
Okay.
it is.
Okay, so this is hepatic artery. You are able to see this one? No?
Yes, sir. Yes, sir.
Yeah, hepatic artery. And bile duct will be approximately the same size of the hepatic artery. So this is the bile duct. So this is the bile duct epithelium. These are the bile duct epithelial cells.
Okay, sir.
And portal vein will be the largest, having the largest lumen. So this is the portal vein. These are again portal venous. Usually, portal vein will be having will be having a few cuts. So we'll be seeing one or two extra. So that's not an issue. Always we will have to compare one bile duct for every hepatic artery. You should have one bile duct. So it will always be 1:1 ratio. So whenever we talk in terms of paucity of interlobar bile duct, we will find the hepatic artery, but you won't find the corresponding bile duct. So you have to count the portal tracts. How many portal tracts are having bile ducts? How many portal tracts are not having bile ducts? Get a ratio, and depending upon the ratio, we'll say that there is paucity or there is no paucity. Similarly, we'll have to comment upon the other structures of the portal tract. For example, if there is any inflammation, whether there is any increase in the connective tissue. So if there is inflammation, whether the inflammation is crossing the limiting plate. So we have to comment in terms of the relationship of portal tract structures and the surrounding. Now this is the hepatic vein. As you can see, this is only one structure. You don't have corresponding bile duct or hepatic artery along with it. So this zone will be zone 3. So these are the zone 3 hepatocytes. So in the previous slide, so the hepatocytes which are surrounding the portal tract will be the zone 1 hepatocytes. So this will be periportal or zone 1. This will be centrizonal or zone 3, and the zone in between 1 and 2 will be zone 2. So these are the hepatocytes. As you can see, the hepatocytes are polygonal. They have regular round nuclei, and most of the times the sinusoids will be compressed. Sinusoids will contain Kupffer cells. So these are the things which we need to keep in mind before interpreting a liver biopsy, because in children up to 5 to 6 years of age, the liver cell plates are arranged in 2 cell thickness. Whereas in adult, if we are seeing 2 cell thick liver plates, then it is always abnormal. As I said, hepatocyte is a polygonal epithelial cell, and it has various domains. Electron microscopically, you will be able to look at all the domains. Whereas in biopsy, we will be able to clearly visualize the sinusoidal site and the canalicular site. So in whenever there is any cholestasis, it is usually the canalicular cholestasis, and sinusoids will contain Kupffer cells. So that is how we will be able to know the pathology. As I said, in adults, the 2 cell thickness is abnormal, and however, binucleation in up to 25% of the cells can be seen. So that is normal. Polyploidy, particularly in persons over 60 years of age, are more common in the zone 2 area or the mid zone. Then nuclear displacement to the sinusoidal pole with hyperchromasia is a cytological indication of regenerative activity. So even without any inflammation, we will be able to know that, okay, there is some liver pathology or regenerative activity, especially if the inflammatory cells are cleared. So this is one particular clue. And hemocyanin and copper should be present, should be absent at the age of 6 to 9 months. Anything which is excess is abnormal. Iron and copper are usually distributed in zone 1, that is the periportal hepatocytes, and it should be normal, fine granular, and lipofuscin is usually distributed in zone 3 or centrizonal hepatocytes. As I said, bile canaliculi are not readily recognized until they are distended in conditions with parenchymal cholestasis. And especially in some conditions like autoimmune hepatitis, where we can see hepatocyte rosetting, you may also find canalicular cholestasis. But it depends upon the extent of canalicular cholestasis and the zone of canalicular cholestasis, which I'll be discussing in certain conditions. Similarly, sinusoidal lining cells, as I said, they are Kupffer cells, and there are certain conditions where there will be abnormality in the Kupffer cells. So you need to look at each and every compartment of liver to find what disease we are dealing with. And elastic fibers and basal membranes are absent from normal sinusoids. So that is why we use basal membrane stains and elastic stains. If abnormal elastic fibers or thickening of basal membranes are present in the sinusoids, then we call it sinusoidal fibrosis. So sinusoidal fibrosis, again, a certain set of diseases are there where we get sinusoidal fibrosis. So what is the distribution of collagen in various compartments of liver? So type 1 collagen is usually present in portal tract, and between the endothelial cells and the hepatocytes, there is a space of this. And this contains hepatic stellate cells or endocells. So there are certain conditions where we find abnormal accumulation of fat in the stellate or stellate cells or the interstitial cells. And so sometimes these cells can be exaggerated in post-mortem samples. So mostly we are not going to deal with post-mortem samples, but just in case we are getting a post-mortem liver biopsy, we have to have in mind. And portal tracts normally do not contain neutrophils or plasma cells. So the presence of plasma cells or neutrophils in portal tracts is almost always abnormal. There are certain immunohistochemistry markers which will be helpful for us. Mature hepatocytes in the normal liver, they contain only cytokeratin 8 and cytokeratin 18. So mature hepatocytes do not stain with alpha-fetoprotein. They do not stain with vimentin, epithelial membrane antigen, cytokeratin 7 and cytokeratin 19. So if any of these stains is positive, then it indicates that the mature hepatocytes are not normal or they are undergoing some transformation, which I will be discussing in the later slides. And cytokeratin 7 and cytokeratin 19 are ductal origin. So, for example, if hepatocyte mature hepatocytes they express cytokeratin 7 or cytokeratin 19, it indicates a ductal metaplasia of hepatocytes. And another marker for mild canaliculi is CD10 and polyclonal PCA. There are other markers like bile salt export protein and MDF3, which I'll be showing it in the coming slides. And sinusoidal endothelial cells, they do not express factor VIII related antigen CD34 and CD31. So expression of these markers is abnormal. Hepatic stellate cells previously which I discussed, they will express synaptophysin, glial fibrillary protein, and neural cell adhesion molecule. So these are some of the markers for various cells in the liver. So whenever we interpret a liver biopsy, these are the minimum liver stain panel which we should see. So HND is must, at least 2 levels should be there. Ideally, we should see at least 5 to 6 levels. Reticulin, collagen. So collagen, it is the collagen stain. It is the choice of the observer. So nascent spectrum is the commonly used, but the other stains which people use are vancomycin and microceres red. Pyridic acid shift, that is the commonly used PAS with and without diasteresis. I will say why we are using both these. And stain for copper binding protein, again, it is the choice of the interpreter. Arsen is one stain. Rubianic acid they use. Then there are rhodamine also. It's another stain, and each and every stain has its own utility. Basically, it is the choice of the pathologist who is evaluating the liver biopsy. Pearl stain or Prussian blue stain is for iron, and it's routinely at least we need to do reticulin. Reticulin, as I said, it is a connective tissue stain, and specifically it stains the type 3 collagen, and the type 3 collagen will appear black. Portal usually stains the portal tract, sinusoids, wall of the hepatic veins. And as I said, it is a silver stain, and it is a property of reticulin fibers to deposit silver. That is argyrophilic. Argyro is silver, and philic is affinity towards reticulin fibers. So silver, when deposited anywhere, will give you a black color, and the reticulin fibers will appear black. It is useful for accessing the overall architecture. And whenever there is any collapse, for example, especially in cases of acute liver diseases like an ischemic hepatitis or acute hepatitis, depending upon the duration, there will be collapse of the reticulin framework, and the liver cell plate plates will be lost. So the reticulin fibers will come closer together. It will indicate a recent evidence of liver cell necrosis. So the pitfall is it can resemble fibrous septae occurring in chronic liver disease. But usually the fibrous septae occurring in normal chronic liver disease will have a golden color, not the black color. So once you are used to the stain, it is not difficult to interpret reticulin. So this is what I was telling. So the reticulin fibers will be appearing black, and the fibers, the individual fibers will be easily seen. So this is the reticular stain. So as I said, it will also stain the structures of the portal tract and central vein. So this is normal. Coming to the collagen stains, so as I said, it is the it depends upon the choice of the interpreter. Commonly used is Mason's triachrome, and the Mason's triachrome will highlight type 1 collagen. Unlike reticulin, which will highlight type 3, Mason's will highlight type 1 collagen. Type 1 collagen will be present in the portal tracts, walls of the hepatic veins, and Mason's triachrome is the stain which is going to assess the hepatic fibrosis, whether it is portal, periportal, perisinusoidal, or pericellular. So without Mason's triachrome, you cannot assess fibrosis. So that is what I'm saying. Just plain HMD is not going to give you the answer with respect to fibrosis. So fibrosis per se, we are going to see in chronic liver disease and to stage liver disease. And there are certain pitfalls where the amount of collagen in the portal tracts increases with the size of the tract and age. Normally, in the core biopsies, the portal tracts which we get are the interlobular bile ducts, and of the smaller portal tracts which we get. Whereas sometimes we may get a large portal tract which may appear to show bridging fibrosis, but again, you can look at the size of the portal tract, size of the bile duct, and the other structures, and know that this is not a small portal tract. This is a large portal tract which has come during the course of a liver biopsy, and they'll appear a longitudinal long section. So again, this is usually not a problem if you have seen a lot of liver biopsies. It is easy to ignore this finding. So this is a portal tract, and the Mason's diagram will give you such a beautiful blue color in the normal portal tract. Whereas in cases of fibrosis, so, this is a core biopsy. This is not even a wedge biopsy. Even in a core biopsy, you'll be able to look at the nodule. So this is a cirrhotic nodule. Why I'm saying cirrhotic nodule is you are having extensive portocentral bridging fibrosis, and the entire nodule is demarcated by the Mason's triachrome stain. So this is a clear-cut case of cirrhosis. So we won't have any problem in calling the cirrhosis in a biopsy. So the other stain is PAS, or pyrrhodic acid shift. So usually it stains the aldehyde groups in sugars by oxidation with pyrrhodic acid, and later on Schiff's reagent will produce a magenta color. So what are the structures which will have aldehyde group in biopsy are glycogen, neutral substances, basement membrane, that is type 4 collagen, and sometimes it won't stain. That is, I'll show you in the other pictures. It will delineate granulomas. Why we are using one more enzyme, that is diastase, is to know the type of the substance which we are looking at. Glycogen will usually be digested by diastase. Whenever there is glycogen, we first give a diastase enzyme treatment so that the glycogen goes up. When you do a PAS will be negative, and we know that the storage material is glycogen. So that is why we use PAS with the diastase. So this is the normal liver. Actually, normal liver will contain a lot of glycogen. So this will appear as magenta within the hepatocytes. These are nothing but nuclei. So nuclei are this is the counter stain is hematoxylin. So nuclei will be a bit blue, and the cytoplasm will be magenta color. So this is nothing but PAS stain without diastase. In certain conditions, for example, here you are finding certain lesions which are not taking the PAS stain. So in high power, as you can see, this is a granuloma. This is a granuloma within the portal tract, and the adjacent liver has taken the PAS stain. The granuloma has not taken. So in the case of granulomatous hepatitis, it usually helps to look at the granulomas which are if they are not apparent on the HLD stain. The PAS will easily pick up the granulomas. The background will be stained by magenta, and the granuloma will remain unstained. So again, a useful stain. Other uses of PAS with diastasis. In cases of alpha 1 antitrypsin deficiency, the alpha 1 antitrypsin deficient substance, that is granules, will be diastase resistant. That is, even after giving diastase enzyme treatment, they will stay with PAs. Other substances that will be positive are glycoprotein, mucin, and ceroid, that is lipofuscin. Basal membrane of bile ducts and bile duct lumen will also be stayed with PSD. And bile duct damage can be assessed in chronic cholestatic liver disease, especially in the basal membrane disruption in primary biliary cholangitis and thickened basal membrane in primary sclerosing cholangitis. So ceroid pigment in Kupffer cells, again, it is not a very specific thing, but can be prominent in cholestasis. And as I discussed previously, it can be used as a screening test for alpha-1 antitrypsin deficiency, which virtually never exists in India. So this is a storage disease where we have PS positive material. After treating with diastase, the entire material is gone. So this is a PS positive diastase sensitive material. Coming to the other state, that is arsen. I prefer to use arsen because it has various advantages. Arsen binds with proteins with disulfide bonds. So the proteins which are having disulfide bonds are elastin, copper associated protein, and hepatitis B surface antigen. So even if you do not have an immunohistochemistry, arsen will pick up hepatitis B surface antigen. And if there are elastic fibers, it indicates long-standing fibrosis. So arsen is also used as a state for assessing chronicity. For copper binding protein, especially in chronic cholestatic liver diseases, Wilson's disease, and vascular disorders. So again, it will be positive. And as I said, it can be used as a screening test for hepatitis B surface antigen. So it is a versatile stain. The only problem with arsen stain is it's a very, very difficult and technically demanding stain. Not every lab will be able to produce a good result with arsen stain. So this is what I was saying. This is a case of Wilson's disease where the elastic fibers are taking up arsen. And these are the copper binding protein, that is cola colored granules, which you commonly see that is described in the textbooks. So cola colored granules indicate copper binding protein. So the other stain is pearl stain. So pearls is hemosiderin and it is not ferritin. Ferritin is a protein, whereas hemosiderin is a iron containing storage material. So it should not be equated with ferritin. Usually it is absent or it is only in small numbers in perivenular hepatocytes and sinusoids. Whenever we do pearls, we usually get it from 0 to 4. The hepatocyte cirrhosis, the grade is usually 2+ and it raises the possibility of hemochromatosis. Again, hemochromatosis gene, in many studies they have shown that it is not a common gene in India, but very rare case reports are there where it has been reported in India. But literally, you can take it that hemochromatosis almost never exists in India. I'm talking about the hereditary hemochromatosis and not the secondary hemocirrhosis. So this is what the secondary iron overload is common in cirrhosis, especially in alcoholic patient and HCV patients, where we find a lot of iron in the hepatocytes. So in the alcoholic liver disease and HCV, there is a mechanism where there is secondary iron overload in the hepatocytes. So this is a secondary hemochromatosis. Whereas when we look at the sinusoidal increase in the iron, we call it hemosiderosis, not hemochromatosis, because the iron will be accumulating only in the reticular endothelial cells, that is the Kupffer cells, especially in conditions where there is hemolysis, recurrent blood transfusion, or systemic chronic inflammatory disease, and so on. So whenever the iron gets accumulated in the reticular endothelial system, we call it hemosiderosis, and in the hepatic parenchyma, we call hemochromatosis. And depending on the genetic and etiology, it is called as primary and secondary. So this is one of such cases where there is accumulation of iron in the hepatocytes diffuse, they will appear golden brown. So when we do a pearl stain, it will appear blue, thick blue. And as I said, iron is graded from 0 to 4. This is definitely grade 4 iron accumulation in the hepatocytes. Other special stains which are used are congruent for amyloid in case of acid-fast bacilli, especially in cases of granulomatous hepatitis. As I said, arsen is commonly, I prefer arsen, but some places they use rhodamine and rubianic acid for assessing copper and copper binding protein. Immunohistochemistry are also useful in certain conditions. You use cytokinin 7, 19, 8, 18, hepatitis B surface antigen, core antigen, alpha-1 antitrypsin, P62 fibrinogen, C5B9, BACP MDR3. Some of the immunohistochemistry I will be showing in the coming slides. And electron microscopy in certain rare conditions which we want to look at the ultrasound finding, especially in conditions like PFIC type 1, where they call mileless bile. It has characteristic electron microscopic appearance. And molecular genetic testing, usually it is these days it is done using peripheral blood. But if we want, we can also do it from the hepatic parenchymal cells. As opposed to the adult liver diseases, pediatric cholestatic liver diseases will need special mention. They usually present with failure to thrive, jaundice, pale stools, pruritus, indicating of chronic cholestasis. Common conditions being biliary atresia, PFIC, positive interloper bile duct, syndromic and non-syndromic. Allergy will cover the syndromic. Medications, especially in adults like NSAID, antibiotic, antiepileptics, etc. But also in pediatric age group, these are the commonly implicated medications. Blood investigations usually complete blood count, liver function test with GGT, coagulation profile, ultrasound abdomen, hepatitis serology. So ceruloplasmin, 24-hour urine copper, and depenicillin challenge test, slit line examination for KF ring, ANA and other specific autoantibody test, and DCT for hemolytic anemia. Sweat chloride for is usually done for very rarely we get in the routine liver biopsies. Liver biopsy in certain conditions where it's appropriate, I'll discuss further. Upper gastrointestinal endoscopy for the screening of viruses. So I'll be moving on to the slides from now on. As I said, see, I've told the normal thing. Now we are going to see the abnormal thing. So this is a portal tract, and the entire portal tract is expanded by inflammation. As you can see, these are the portal veins. There is it is difficult to actually find out the bile duct. Actually, this is a bile duct, and there is a lot of inflammation. Now, if you look at the inflammatory cells, they are a mixture of inflammatory cells. So mostly they are plasma cells, few eosinophils, and lymphocytes. So this is one plasma cell. This is a plasma cell. This particular picture, as I said, is a portal dominant inflammation. I can see this is a bile duct. So you can see the lumen of the bile duct here. So you'll be able to appreciate, but it will be difficult to appreciate in routine stains. But when you find a lot of plasma cells, a lot of inflammation in the portal tract with this is interface hepatitis. As I said, the limiting plate is the inflammation is crossing the limiting plate. So this is an area of interface hepatitis. So we have a dense portal tract inflammation, plasma cells, interface hepatitis. Common etiology which we'll be looking at is the autoimmune hepatitis. So this is a case of autoimmune hepatitis. So this is a case of drug-induced liver injury, DILI. This is a central vein. The main pathology is centered around the central vein. As you can see, normally we should not be able to look at the canaliculi. But here the canaliculi is markedly dilated. We are having these bile plugs within the canaliculi. To appreciate the zonal distribution, this is a trichrome stain, and we can see this is a central layer. So the entire zone of cholestasis involved is predominantly zone 3. So typically in drug-induced cholestasis, we have a zone 3 pathology with cholestasis. However, drug-induced cholestasis can produce any pattern of liver injury, but the common pattern is canalicular cholestasis, especially zone 3. So this is a case of granulomatous hepatitis. We can in the previous slide also I've showed you. This is well-formed. These are well-formed granulomas. This is a granuloma. This is a granuloma. And these granulomas are devoid of PA stain, and the surrounding hepatocytes are positive for PA stain. So this is a granulomatous hepatitis. So actually, this was an interesting case. As I said, frozen section. I thought that I'll show you on the frozen section. This was a donor liver which I received to assess the fitness for taking this liver for transplantation. So this had a lot of steatosis. At least it was more than 30%. So this is wedge biopsy. Again, it showed more than 30% macrovesicular steatosis. So this was from another lobe. I think this was the right lobe. This was the left lobe. So basically, I signed out that this has more than 30% fatty change. So not to take this liver for transplantation. So when it was processed, when the frozen remnant was processed, and we did IHC for P62, there was a lot of P62 positive material, and these are all ballooned hepatocytes. This was a case of NASH, and we also have inflammation. So it was a steatohepatitic NASH. Lucky that this liver was not taken for transplantation. So this is a case of Wilson's disease. So in Wilson's disease, we have degenerated hepatocytes with a lot of this ropey eosinophilic material in the cytoplasm. So this ropey eosinophilic cytoplasmic material is called Mallory hyaline. Previously, now it is called Mallory dead body. This is nothing but an intermediate filament within the hepatocyte. Along with that, we have a good amount of pericellular fibrosis around the hepatocytes. So when we do a trichrome stain, the Mallory dead bodies are highlighted as reddish material in the trichrome stain. So this is what I said. This is arsen stain, that is copper binding protein is actually increased. That these are nothing but cola colored copper binding protein material within the hepatocytes. So we have extensive Mallory dead body. We have copper binding protein. We have extensive pericellular fibrosis. We have inflammation. So this is a typical case of Wilson's disease. So this is a case of nodular regenerative hypoplasia. Ultrasound will look like a typical cirrhotic liver, but on biopsy we will not find any fibrosis. This is HMD, but even in the HMD, you are able to look at vague nodular pattern. Here is a vague nodule. Here is a vague nodule, and in between these two nodules, the hepatocytes are actually compressed and they are atrophic. Similarly, here these are all atrophic hepatocytes. This is one nodule. These are atrophic hepatocytes. So this is a typical case of nodular regenerative hypoplasia. See, this is a PA stain, where you can see the atrophic hepatocytes, they are intensely taking up the PAs, whereas the nodules are typically negative. This is a trichrome stain. This was what I was saying. So these nodules, trichrome stain, the bluish color is only confined to the portal tracts and the central veins. Whereas around the nodules, we are not seeing any trichrome, which indicates that there is no fibrosis. So this is a nodular regenerative hypoplasia, commonly equated to idiopathic non-cirrhotic portal fibrosis, NCPF. So in this case, if you do a cytokeratin 7 stain, the atrophic hepatocytes will be cytokeratin 7 positive, and the regenerative nodule will be negative. So these are some of the clues to find out what etiology we are dealing with. So we had seen the portal tract lesions. Now we'll move on to the central vein lesion or vascular lesions. As I said, central vein we should be very thin, and it should not have this much of fibrosis surrounding it. And as you can see, the central vein is much thick and fibrotic, and a lot of hemorrhage is seen in the zone 3, that is centrizonal hemorrhage, and loss of hepatocytes in the centrizonal area. Trichome stain beautifully highlights the thickened central vein, narrowed lumen, and lot of hemorrhage around the central vein. This is a typical case of hepatic venous outflow tract obstruction, and this case was Budd-Chiari syndrome. So for hepatic venous outflow tract obstruction, you need to evaluate various causes, and it may be even right heart failure also. But if you have excluded right heart failure, then you think of Budd-Chiari syndrome. So this is a portal tract area, and we are seeing completely fibrosed portal tract with plenty of bile ductular proliferation, lot of canalicular cholestasis in zone 1, lot of neutrophils in the portal tract. This is a case of vanishing bile duct syndrome. We don't have any bile duct. This was native medication induced. So again, for drug-induced liver injury, we have canalicular cholestasis, lot of neutrophils, and vanishing bile duct. So this is one of the etiology of native medication intake, vanishing bile duct syndrome. Sometimes if it is so severe, you can have these lot of infarcted hepatocytes, which are nothing but due to bile stasis. This is called bile infarct. Lot of cholestasis, the hepatocytes will be distended and ultimately they undergo necrosis. So this is a bile infarct, indicative of cholestatic liver disease. Secondary, in this case, it was secondary to vanishing bile duct. Adults usually we don't get this type of pattern, that is giant cell hepatitis pattern. In adults, usually we get a canalicular cholestasis as a part of regeneration, or we get pseudocyte transformation and so on. Whereas in pediatric liver diseases, especially in neonatal cholestasis, we find this type of giant cell transformation of hepatocyte. So this is one single hepatocyte which has multiple nuclei in the cytoplasm, and this is nothing but feather degeneration because of cholestasis. So this whole thing is a hepatocyte giant cell. This was a case of neonatal giant cell hepatitis. Actually, these days, this terminology should not be used. Whenever we use a term, we say it is a neonatal giant cell hepatitis pattern of liver injury, because there are various etiologies where we find this pattern, this typical pattern of liver injury. Even in PFIC, we can get this. So this is a pattern of liver injury in children, neonates. So this is one case of post-mortem liver biopsy which I received, and there was a lot of hepatocyte necrosis, degeneration. Along with that, lot of iron deposits were seen within the parenchyma of liver cells. This was a case of neonatal hemochromatosis. Pearl stain, very useful stain. So this is again a typical case where the hepatocytes show a plant cell-like morphology, where they have distended pale eosinophilic cytoplasm. You can see this is new. This is a new case, and you can see that these are intranuclear inclusions, which are nothing but again glycogen. So when we do a PA stain, even the glycogen intranuclear inclusion is again magenta colored, and the cytoplasm is magenta colored. When we do a diastase treatment, the entire thing goes off, which means that whatever substance which is being stored in the hepatic parenchymal liver cells are nothing but a glycogen. So this is a glycogen storage liver disease. So this is a case of PFIC. This is the, as I said, this is the pseudocyte transformation of hepatocytes. Previously, I showed you giant cell pattern of hepatitis pattern of liver injury. This is a pseudocyte transformation of hepatocyte, again abnormal liver parenchymal liver disease. So canalicular proteins, one of the canalicular protein is BSEP, that is bile salt export protein. In this particular case, it was retained. So this case showed preserved bile salt export protein, indicating that this is not a PFIC type 2. Whereas MDR3 in this particular case was completely lost. The canalically didn't show any MDR3. So this is a normal control which we did along with the case. The normal control showed a MDR3 positive, which means that That particular case has in that case there was loss of MDR3 protein, indicating that that is PFIC type 3. PFIC is progressive familial intrahepatic cholestasis. Rarely we get alcoholic liver disease. The injury is similar to that of NASH. We find a lot of malarine antibodies, extensive hepatocyte feather degeneration. And compared to NASH, usually alcoholic liver steatohepatitis will also have cholestatic liver injury also in the biopsy. Trichrome stain will highlight a lot of pericellular fibrosis as well as reddish malarine antibodies within the hepatocytes. So in certain conditions, which we also have to look at the sinusoids. So in this case, the sinusoid is showing expansion by these cells, and each cell is engulfing mononuclear cell as well as an RBC, which means it is erythrophagocytosis and leukocyte phagocytosis, which means it is hemophagocytosis. So this was a case of hemophagocytosis of liver. So I have discussed some of the common conditions involving the certain compartments of liver. If we move on, there are certain neoplasms of the liver. Common neoplasms is a hepatocellular carcinoma. So this is a hepatocellular carcinoma. In this case, we are finding bile, which is produced by the tumor. So if I find bile, I can very well say that I am dealing with a hepatocellular carcinoma. One more important special stain which we use is reticulin stain. In hepatocellular carcinoma, there will be loss of reticulin. We are not finding that reticulin thin fibers which I showed you previously. Hepatocellular carcinoma will have reticulin loss. This is a cholangiocarcinoma. Usually, it's an infiltrative tumor. It is trying to mimic the normal bile duct, so this will have a ductal morphology. The important finding in cholangiocarcinoma, it will have a lot of fibrosis around. So this is a strong. It has a strong desmoplastic stromal response. So this is a metastatic adenocarcinoma. So we can find multiple cribriform spaces, and in scan usually it will not be a single lesion. It will usually be a multiple lesion, unlike the primary liver tumors. Like, HCC usually it will be single, but there can be multicentric HCC as well as cholangiocarcinoma. But commonly HCC and cholangio will be having a single lesion, whereas metastasis will almost invariably will have multiple lesions. Again, this is another liver tumor, but it is not a carcinoma. But these are atypical lymphoid cells, large cells, which are infiltrating the liver parenchyma. This is diffuse large B-cell lymphoma. This is a CD20 immunostate which is showing strong membranous positivity in the atypical lymphoid cells. So to summarize, I will say. Why do we need a liver biopsy, and what is the purpose of the liver biopsy report, and what it implies to the clinician is it should identify the pathogenic type. It should describe the disease process, pattern of liver injury. If we are able to pinpoint the diagnosis like an autoimmune hepatitis, then give a score, a modified Ishak score, grade, stage it. If there are any additional features like autoimmune hepatitis with the component of drug-induced liver injury, really comment on it. If we have a secondary diagnosis, again, comment on it. And finally, give a bottom line diagnosis. So I think I can conclude with it. If you have any further doubts, you can ask me. Thank you.
Thank you very much, sir. That was a lovely presentation. I enjoyed and learnt a lot. I'm sure everybody would have learnt. And the postgraduates now can ask questions. Please unmute yourselves. If there are any doubts, please go ahead.
Not a postgraduate, but definitely I have a question. This is a
Yes.
very basic doubt, sir. So you said that the oxidative gradient also indicates, and also the metabolic gradient. Based on
Yes.
these
Yes.
two
Yes.
and the overlap, the zone 1 to
Get the question what Madhura was trying to ask. You can
No, sir.
go ahead and give the answer, sir.
No, I didn't hear. I didn't hear, sir. Can you please repeat it, sir?
No, even I couldn't hear properly. Uh, doesn't matter.
Better?
Maybe. Yeah. Madhura?
Is it better? Is it better now?
Yeah, yeah. Go
Yeah,
ahead. Go
it's
ahead.
yeah. Yeah.
Now it's clear? Okay, no. There is an oxidative gradient and also there is a metabolic gradient in diseases
Yes,
where
yes, yes,
because of which the zone 1 to zone 3 is positioned. So
yes.
drug-induced liver injury is basically a zone 3
Correct,
involvement you can see. Is
correct,
correct?
correct,
And
correct.
if it's an ischemic, you'll be seeing in zone 1. Is it correct, sir? Or is it the other way?
Mostly in ischemic also it will be zone 3 only. Especially it depends on what type of ischemia you're dealing with. Like, for example, you are dealing with a hepatic venous ischemia or an arterial ischemia. It depends upon where which ischemia you're dealing with. So if you are dealing with a venous ischemia, mainly it will be zone 3. If you are dealing with an arterial ischemia, mostly it will be around zone 1.
Madhura? Yeah. And also, this viral hepatitis, it'll be around the portal triad, in zone 1.
Yes, yes,
Whereas the alcoholic liver disease and the non-alcoholic steatohepatitis, it's zone 3. It's around the central vein.
yes,
That's where it starts.
yes.
Sir, why this change, sir, between viral hepatitis and the other group?
Uh,
Even DLE also mostly starts around zone 1 only.
Correct, sir. Correct. So because as I said, the connective tissue will be more in the portal tract, and the portal tract will have a lot of lymph and some inflammatory cells will be there. Always will be there in the portal tract. So first response will be from the portal tract in viral hepatitis as well as autoimmune hepatitis. Whereas the other conditions like as you said, alcoholic liver disease or NASH, it will be affecting the central vein first. The central vein will first be affected, and the sinusoids, there will be sinusoidal fibrosis and so on because of the metabolites in the alcohol. Whereas in NASH, whereas in NASH, again the propensity will be around zone 3 hepatocytes. Then the disease progresses from zone 3 to involve the entire liver. So at that particular point, we will be scoring what is the percentage of fatty change which we are dealing with, less than 5%, 5 to 33, 33 to 66, or more than 66. So, and most important thing which we need to look at in NASH will be the ballooned hepatocytes. So once we find ballooned hepatocytes, it is almost typical of NASH. And again, ballooned hepatocyte will has its own definition, and usually it will be, I think it's at least 3 times the size of the resting hepatocyte, if I'm right. And it should contain malaria hyaline with lot of degenerative changes. So that particular cell we call it a balloon hepatocyte. If you do a P62 stain, the malaria hyaline will be highlighted. Whereas in alcoholic liver disease, usually you don't get that balloon degeneration. That is one important finding which distinguishes fatty change from an alcoholic liver disease from a typical NASH.
Sir, this ballooning degeneration is okay. Do you get a feathery degeneration in NASH or no?
So feather degeneration, if in many of the reports I've seen that terminology is actually abused. So when we see when we talk in terms of feathery degeneration, I'm talking in terms of cholestatic liver disease. Uh,
Okay, okay.
when I use the term feather degeneration, I usually use the term, and it is recommended by the standard text solely for cholestasis. So we should not use certain terminology in certain conditions. Feather degeneration can be seen in many conditions, whichever condition affects the hepatocytes, and in whichever condition there is intrahepatocytic cholestasis. It can be seen in AIH, it can be seen in cholestatic liver disease, it can be seen in urinary hepatitis, and so on. So that is not a very specific thing. But when someone says that there is ballooning degeneration, it is very specific for NASH.
Also, I
Sure.
have another doubt about Mallory Denk body.
Yes, yes, sir, yes.
I think if there are no more doubts, Madhura can clarify over a phone call, sir.
It's okay.
So thank you so much. You've taken more than an hour, and this will be posted in our VGM hospital website. So you can even give a reference to anyone who can visit and also can learn. So thank you very much. And AB, please post it in our hospital website. Thanks a lot to all the postgraduates. We'll also circulate to all postgraduates across the country. Thank you so much, sir. Thanks once
Yes.
again.
Thank you, sir.
Very grateful to you. Thank
Yeah.
you.
Yes.